You're live.
Good afternoon, everyone. Thank you for being here with us today. I'm Frances Padilla, President of Universal Healthcare Foundation of Connecticut. And the focus of today's program is the impact of the pandemic on our mental health and what kind of system we need moving ahead. This program today is part of a ongoing series of conversations we've had this year about the lessons of the past 17 months and what they tell us about the future. In earlier programs, we've spoken with leaders of community health centers, local public health departments, and hospitals. Today, we have two dynamic speakers and leaders in behavioral health, and we will explore this left out topic of how the behavioral health system fails to support mental health as key to overall health and well-being. It's a really critical topic. We're very salient in the media, but it has been with us for a very long time. So I want to take a moment to thank our sponsors before we start our conversation. Our series sponsors are Eastern Connecticut Health Network, the Foundation for Community Health, and our parent organization, Connecticut Health Advancement Research Trust. Our session sponsor today is the Main Street Community Foundation, and our series supporters are the Donahue Foundation and the Connecticut Health Foundation. So I think we're just going to go ahead and get started. I am happy to introduce our speakers today. I'm really looking forward to the conversation with them. They each have extensive and impressive bios. I am not going to read through all of that. You've already seen their bios. Dr. Maisa Akbar is an expert who has written extensively, on the impact of racism and urban trauma on mental health. She's currently the Chief Diversity Officer at the American Psychological Association, where she is leading the field in its adoption of best policies and practices in diversity, equity, and inclusion. Before now, she founded a clinical practice called Integrated Wellness Group, a multidisciplinary psychotherapy practice serving New Haven and surrounding communities of urban kids, adults, and families. And she has also taught at Yale School of Medicine. Patricia Reamer, who I refer to as Pat, is a nationally recognized leader with a wealth of experience and expertise in the field of mental health, substance abuse, and addiction. She started her career as a registered psychiatric nurse and went on to become the commissioner of the Department of Mental Health and Addiction Services in Connecticut under at least a couple of governors. And is currently president of the Behavioral Health Network of Hartford Healthcare. So we are in excellent company today to treat this very complex subject and timely and important matter. I'm happy that so many people have joined us today. I want to make sure that everyone joining us understands that we're in conversation with each other. We'd like you to interact with us by putting your questions in the Q&A function, not in the chat, but in the Q&A function, and we will bring your questions into the conversation. I'm also reminding everyone that we're recording the conversation so that those who aren't able to join us can, in fact, listen in at a later date. So shall we get started, Maisa and Pat? Thank you for being here. I would really like to start by, anchoring our conversation in all of this recent media coverage of the mental health crisis in Connecticut and nationally among children. In Connecticut, we saw a 31% spike. I ask everyone to put themselves on mute just to avoid the background noise. Thank you. But in Connecticut, there was a 31% spike in emergency room visits from 2019, with girls aged 12 to 17 particularly prominent among suicide attempts. And, why is this not a surprise for either of you? Maisa?
Well, I think that there's a lot of areas that we can talk about here. One is that we're dealing with children that were significantly impacted during the time of COVID. We know that the data has demonstrated that there was severe levels of isolation, lack of social connectivity, the disengagement from school, having to find a completely different way of engaging in their educational process through a virtual learning environment.
Yeah.
And to do that with no leeway, no understanding of what was going to happen, and absolutely no anticipation of when or how this was going to end. Not to mention the amount of children that have lost a loved one along the way. In a few months ago, right at the beginning or so of October, APA conducts a survey that's called Stress in America, which actually looks at like what are the factors that lead to the things that you were mentioning, Francis? Elevation in anxiety and depression, the spike in suicide that we've now seen in adolescents. How does it look in terms of racial demographics? And what we saw was that when you look at stress, which is one of the social determinants that lead to, you have poverty and you have all these other social determinants that spike stress along the way, and that can lead to mental health issues. The biggest community in terms of age that was impacted were the Gen Zs. And what we saw was that this population between 18 and 24 years old were struggling with things such as, just daily tasks, accomplishing daily tasks, wanting to engage in ways that are meaningful, but couldn't. And more so than any other generation, you saw that Gen Z was affected in a way that was significantly correlated and connected to the decline in their mental health. So knowing that, we have to kind of think about, well, what does that mean? And if you think about that 18 to 24-year-old, all the seniors that didn't get to go to graduation or prom, all the freshmen in college that didn't get to experience their first time on campus, even though working for how many years in school to get to this moment. Think about the impact in terms of how their lives were turned around and what that means in terms of a trauma effect for them moving on into the future. We can't switch a light and say, we're back to normal now, because that really doesn't exist.
Right. And the trauma is lasting, and particularly if it predated COVID as well, right? So Pat, why doesn't it surprise you?
I think for a lot of the reason that Maisa said, the children were so isolated, the adolescents were so isolated, and we know during adolescence and young adulthood that peer relationships are critical. And if you don't have that, while we often sort of talk about peer pressure in a negative way, but there's peer pressure in positive ways as well. And so I think the adolescents and young adults that weren't having the experiences that they had anticipated, it really impacted their mental health in a way that I don't think any of us were prepared for. I heard an interesting statistic a week or so ago. There's 800,000 children and adolescents in the state of Connecticut. Typically, for a mental health issue, you say it's going to impact 1 in 4, maybe 1 in 5. At this point in Connecticut, we believe that 1 out of 2 adolescents is experiencing some sort of mental health issue, if not a crisis, an issue. And that is very, very concerning.
From 20% to 50%.
That's right.
We've gone.
Yeah.
In a matter of 17 months. Think about
That's right. That's right.
That's a national emergency. That's a state emergency.
Mm-hmm.
And we are in many ways behaving as if it's over.
Yes.
Right? Trying to create an illusion of, oh, we're back to normal. And
I
that,
think, Francis, just adding to what Pat said, the other piece of this is that most environments, even if children are transitioning back to school, so now they're in their school buildings, most school environments were already grossly understaffed in terms of mental health supports, right? And now what you're doing in terms of compounding, coming back from a COVID crisis, and without any infrastructure change to the mental health services of children, saying, all right, well, they're back in your classrooms again, no additional training on how to support, children who have lost loved ones, who feel isolated, who are depressed, who have been to an ER, and the expectations without infrastructure change to the educational system, really leads to a worsening of these symptoms over time, because teachers are just not well equipped, and schools are not well equipped to deal with the mental health issues that are surfacing to the level. So we've got to think about this from a dual perspective. It's not just sort of like the emotional impact to the individual, to the child, to the family, to the community, but also how do we respond to that? How do systems respond to that?
Systemically, exactly right. Yeah. I recently heard Senator Chris Murphy in an interview talk about how we in Connecticut in particular have to decide if we're going to build that infrastructure within our school systems in a way that makes it possible for them to identify, right? Because prevention is important and intervention is important. But capacitate districts to be able to identify and intervene. Or if we're not going to do that, then capacitate systems to identify and refer to real systems in the community. And I think I want to use that to pivot to ask you about, we've talked about how in the height of the emergency, we were able to see the move, for example, to telehealth, something that, 2 years ago, people said, oh, that's still 15 years out in the future. Nobody's going to want to do telehealth. So for a decade, we've been all saying telehealth makes sense, and we pivoted to it pretty successfully. It doesn't work for everybody, but tell us a story of what it feels like as a patient and a provider trying to help people in crisis or about to be in crisis get what they need. And what's working? What has worked well that we would like to keep? And what hasn't worked so well?
I can talk a little bit about a program that I think that is working particularly well, and I actually think will help us with some of the staffing crises, because the bottom line is the other thing we're seeing is staff are leaving in droves, whether that's related to the pandemic, whether it's related to burnout. People are leaving hospital settings, leaving acute care settings, leaving community settings, and leaving. And so how do we address the need for actually more staff when people are becoming, I think, disillusioned, right? So one of the things that's very strong in Connecticut, Francis, that I think you know about, is that we have a very strong advocacy community. And there are multiple agencies that do this, but at Hartford Healthcare, we received a HRSA grant a few years ago to educate people with lived experience so that we could have them get jobs in the system as recovery support specialists or recovery coaches. And one of the reasons I believe we got the grant was we started this, what we call a Recovery Leadership Academy. And when the pandemic hit, we were able to get support to do it all virtually. So we didn't have to stop the process. And so we are graduating about 40 to 50 people every 3 to 4 months. We are giving people internships. And so, and I can't tell you how effective peer support is for kids. We're working with DCF to see if we can use young adults to do this. We're doing it in our emergency departments when people come in, so people can tell them what they've been through. And, actually it's about giving people hope. So I see that as another answer to this question, which again, we probably turn to more quickly than we would have under normal circumstances, which I think is great.
And which is also, it seems to me, a way to bring more staffing resources into the system when clinicians who made the pipeline for clinicians may be too short, and it takes longer, right, to get people ready to practice in clinical settings. That needs to happen too, all of that. And there need to be more people who are multilingual, and there need to be more people of different racial and ethnic backgrounds. But this is a way to sort of shore that system up.
Right.
It feels to me. Maisa, what are you seeing?
Well, I like to kind of share a personal story, which I think sometimes, as a psychologist and being in an infrastructure that advocates for this type of, this type of stuff all the time, you can be one person removed, and it becomes very theoretical. But then when it hits home, it changes your entire way of thinking about this. So I'm Dominican. My family, I have a lot of family that lives in Boston that speak primarily Spanish. And right sort of a couple of months after the pandemic began and we were on total lockdown, my cousin calls me and she says, I think my mom, who's my aunt, my mother's sister, has COVID. And she's like, I'm freaking out. I don't know what to do. Both of my aunt and uncle are elderly in their 80s. And she's like, but I don't know how to get her tested. I don't know what to do. I think that if she's got it, my dad's going to have it. And I had to talk her through that process. Here's sort of telehealth familia style, right?
Right.
Here we have the video, and I'm talking her through the process. Turns out that they tested positive, and immediately what we started to see was a drop in their oxygen levels. And, they're compromised. They have so many pre-existing health conditions, from diabetes to heart disease, you name it, because remember, we're talking about communities that were already disproportionately affected before COVID, right? And so the interesting part of this, I said, you've got to get in the car and you've got to take them to the ER, and you're not going to be able to go in. And so she's crying and she's hysterical. She has both my aunt and uncle in the car. They're hysterical. And she's like, how am I going to communicate with these doctors, right? And so here's the beauty of the capacity to have transitioned as quickly as we did during a COVID crisis. Well, what happened? I was able, from Connecticut, although they were in Boston, to start speaking directly to the attending and the docs that were there, caring for my aunt and uncle, speaking to them in a language that they understand. So I was speaking and translating for them in English to Spanish, and making sure and assuring that they got the care that they needed, right? Thank goodness my aunt and uncle did really well with oxygen treatment. My uncle was released first, and then 2 weeks later, my aunt, and they're fine now. But I have to think about, Francis, and I reflect on this, and I know, Pat, with what all the things that you're focused on, you have to see this all the time, that there was this moment of panic for me. What if these tools were unavailable to doctors to get in touch with families? What if telehealth wasn't approved as quickly as it was? What if they had to go in there on their own without knowing the predominant language for frontline workers and healthcare workers that were under an incredible amount of stress to now have to deal with language barriers, symptom identification, and understanding what to do in terms of treatment planning? So all of these things are essential tools for physicians, for mental health providers, for everyone in our community that's working with people, and to create health equity. We can't talk about health equity unless we talk about access, And so I think that from a very personal level, the idea that we have to become more nimble and agile in this space is not just a want or a desire, it's a necessity.
It's a necessity. It's absolutely a necessity. And to be honest, prior to COVID, for the few years before the pandemic, my mother was declining rapidly and very, very, very sick. And the amount of advocacy that is needed on behalf of a person. My mother's birthday would have been today, actually, her 92nd. My mother lived her entire life with mental illness. And I remember all the advocacy and the running interference that I had to do for her. And without that, right? So to your point about recovery specialists and recovery coaches, community health workers, that's a whole nother. But part of the problem is, one, people don't know about that, right? They don't know that either that opportunity to play that role exists. A lot of physician practices are isolated and don't actually, even in systems as big as Hartford Healthcare, don't have those resources at their disposal. The patient is caught in the middle, right? The patient is basically up against the wall. And we need a system where these mechanisms are immediately put into play. Immediately, not after the fact, and not by serendipity because they happen to have a well-educated cousin or a well-educated daughter. It shouldn't rely exclusively on that. So let's shift to trauma, right? Because this adds trauma to whatever trauma you already have. It's a traumatic conversation, to be honest. So we've been working for the past year, talking with community organizers in Connecticut about doing more work at the community organizing level. And we're getting ready at Universal to move into deeper work on that front. Community organizers have been telling us that the trauma experienced in the healthcare system, just trying to get care, and other systems actually is very, very on the surface, very, very much in front and center in the organizing work that they do. And it affects everyone from kids on through the elderly, right? So what I want us to talk about a bit, because we know that urban trauma is a real thing, that Black kids, Black people, Latinx people are disproportionately affected by trauma. So how has COVID exacerbated that, and how do we address the particular needs of communities of color? And I'm going to turn to you, Maisa. I know you've written about this, you have lived experience, and at the American Psychological Association, you're trying to make some changes on that front.
Yeah. Racial trauma and urban trauma is my life's work. It's my passion. It's what I try to define for community members, because I think that it's a fairly new way of thinking about traumatization and the intersection between racism and mental health. I think oftentimes when we look at the world of behavioral health, racism was seen as a social political issue, and it was distinctly separated from what it meant in terms of the health and well-being of populations of color. And now I think that there's a much greater understanding and recognition that there is an interaction, and that the interaction has, very negative effects on the lives of people of color. So just for definition purposes, racial trauma is a cumulative effect of racism that can lead to an individual's mental and physical health deteriorating, and can lead to, official mental health diagnosis or psychological diagnosis of anxiety or depression, or you can have suicidal ideation and a host of physical issues. So this is the important part, is that while we are starting to think about racial trauma in terms of the intersectionality between racism and mental health, it is also the intersectionality between racism and physical health. And so we're looking at things like the level of high blood pressure, obesity, these other ways in which physical health is affected and impacted as a result of racial trauma. The other thing that has been very clear, and we're starting to see much more data around this, is the intergenerational impact of racial trauma. So it's not like you're exposed, and now you're the only person in your family or the only generation that has experienced racial trauma. Instead, what the research and the literature is suggesting is that there's inherited trauma that happens, that is passed down and can be passed down from one generation to the other, and can also impact you throughout the lifespan, meaning that it's not like a trauma event happens and then all of a sudden you get rid of it. It begins to show itself in different ways as you grow, as you develop in your relationships and community, and everywhere that you sort of show up. And it can become very chronic and pervasive over time, particularly in communities of color, because there is a lack of alleviation from the exposure to racism. It's not like, you know, you have a situation with racism. Let's say you're stopped by the police without any good reason, and it's because you're being profiled due to the color of your skin or who you are in your community, and then that just ends and then there's no trauma effect. No, that particular trauma effect is untreated, that's right, continues to impact you and affect you throughout the lifespan unless you get support and help on treating that situation. So I think it's important for context for us to understand. And then I'll leave it with this. Here's the thing about racial trauma work, and I think the message that I've really been trying to get to people, right? And it's a different way of thinking about behavioral health, moving it from a medical model of symptom focus, and those symptoms lead to a disease, to asking questions a little bit differently, right? So we should be asking people of color who come in as a result of racial trauma, not what's wrong with you. Instead, the question that we should be asking is, what happened to you? Very, very different way of approaching from a systems of care, approaching the patient, right? Because right, medical model tells you what's wrong with you. What are all the things that are happening with you?
And how can we fix it, right?
Exactly.
Right.
And how can we fix it?
Helps you understand much better.
You got it.
So Pat, can you reflect on the system that you are within, right? A big mega system. How does this distinction that MISA has brought forward actually, you know, is it understood? Is it acted on within the Hartford healthcare system of care?
Well, I think first I have to say this because it's burning in my mind. And I've said this before, if you've heard me speak, I don't use the word stigma for individuals with mental health disorders or behavioral health disorders. I think people are treated with discrimination, and that comes to jobs and housing. So if I think about the discrimination that a Black individual is experiencing, and then they get a mental health diagnosis, you're really working within two different ways that people are going to be discriminated against. I think the way we are addressing it in the behavioral health network specifically is that we focus on actually what Misa was just talking about. She was describing a recovery model where you ask people, what are your assets? Not what are your problems? What do you want to work on? What are your goals? And getting away from the parentification that we had for years in psychiatry, where we told the patient what they should do and how they will get better. I mean, when I started many, many, many years ago in the 80s, the patient's charts were not on the inpatient units because the nurses were not allowed to see the diagnoses. So obviously the patient never got to see their diagnoses. Now we have a CMS regulation that even in behavioral health, the patient owns the chart and they have the right to look at the chart at any time. And I can tell you that it really disturbed people at first because they were very concerned about it. And what we said is, you shouldn't be concerned about it. You just need to make sure you're writing your notes appropriately, and you should be talking with your clients about what their diagnosis is, what they want, you know, what are their future goals. So I think if you can embody that recovery model, you move away from some of the discrimination that can happen almost unconsciously within the group.
You know, there's an observation in the Q&A right now that I think is relevant to this conversation, and it's Sonia Hernandez says, what happens when members of the community go to the clinic or the hospital and they give you an interpreter, but that interpreter doesn't actually say what it is that you want to express, and that you are unable to express what you're feeling in your own language, right? And this question, what happened? This issue of diagnosis is very tied up with communication and people understanding one another, right?
Yeah.
So we have had stories over the 20 years of the foundation's life from so many people who have had this very experience of saying this but being misunderstood. That is an age-old problem, and certainly with COVID, I mean, thankfully your aunt and uncle have a bilingual niece who could speak not just English and Spanish, but medicalese, because that happens a lot.
Yeah.
The medicalese, is just like, and doctors and residents don't stop to figure out, like, how can I just speak plain language to the people in front of me?
The other result of something like that is that you often see individuals who have a history of behavioral health disorders who arrive at an ED, and especially during COVID, and may have had physical complaints, but they are relegated to the behavioral health unit in the emergency department, and their physical issues are downplayed because people are certain that it's really their psychiatric issue. Just another great form of discrimination. But that's where, when we have the peer supports there, they can help and meet the individual where they're at. And I think that's just invaluable.
And Francis, can I just add a little bit to that? I think, we also have to consider that by the time, a person of color makes it to either a therapy session or the ER, because they have literally tried everything else before getting there, right? They've talked to pastors and spiritual leaders. They've talked to family. They've gathered, they've made every remedy casero that you can find. I'm going to mash up this leaf with that leaf and boil it and put some lime and lemon in it. And so they've tried everything. And so you have to think about, like, each of these touch points with systems that don't understand the cultural importance of communities of color chips away at a person's dignity, and that chipping away over time, what some researchers call weathering, right, is a direct predictor for poor mental health outcomes and a host of physical problems. I mean, there are researchers that have literally stated that racism itself is a killer. It is a killer, right? That's why we're talking about this, either from the perspective of a dual pandemic or a syndemic, because we haven't really started to unpack and understand what are the implications of the deterioration of mental and physical health for communities of color, and elevated a way to intersect that continues to chip away at people's both dignity, their health and well-being, and how they can advocate for themselves in these kinds of situations. So it's so important for us to consider that as we're having this discussion.
Well, I'm thinking that, this whole series of conversations was born from our feeling that we have to think about what we've learned, right? And what we've done differently in the collective, and moving forward, how we make the changes needed. Our organization has always been about structural change. And, the pandemic, basically, it's like rising from the ashes. And we have an opportunity to create something new here. So I guess what I want to ask you to reflect on is what do you think? What are the important learnings that you've taken away from the pandemic, and the solutions that you see? And if you can identify a couple of priorities based on the conversation we've had so far that you think really have to get attended to in order for there to be, a behavioral health system, a healthcare system that is not just reactive, but responsive and proactive in eliminating these disparities. Either of you can jump in.
I think that we have learned a lot, and I think that there are ways that we need to approach the system for systemic change. So when people hear about overcrowded EDs, everybody wants more beds. The reality is that more beds probably, I mean, we might need some more beds. I'm not saying we don't, but I think the reality is that we need a community system that really works in the communities where people live to provide this care that people need. And this care, by the way, is not just outpatient therapy or just, a couple of therapy visits. There are people that need community support in a very, very different way. And there are services like that funded through the Department of Mental Health and Addiction Service. But here's the catch for this. If you're privately insured, you essentially have inpatient care, partial hospital care, intensive outpatient care, and outpatient care. That's it. It doesn't matter what your diagnosis is or what you're dealing with. If you are in the state system, you have access to community support programs, to ACT teams that go into people's homes to help them, figure out how to live in the community, and just a variety, vocational services, housing services, a variety of different things that people can avail themselves of. There's not enough.
But how do people even know that those exist and how to get to them?
I think that is the most important question. It is impossible to navigate this system. I get at least 1 or 2 calls a week from either a parent or a sibling who is trying to figure out how to get their family member, their loved one, what they need. And we are not good at making it easy. That is for sure. And so a lot more community education, I think, needs to go on. I think we really do need to do more neighborhood wellness sorts of initiatives with a focus on mental health rather than it being the afterthought. Because really what we are doing a little bit of neighborhood health at Hartford Healthcare in 2 communities. And what we are seeing, and everybody is shocked by this, is that the majority of the clients that are being seen are either have a substance use disorder or a serious mental health issue that has not been addressed. And so if we're not out in those communities screening and looking, we're not going to get people in.
Okay.
This has, I think, direct implications for the work that that you all do, right? Because I think that you positioned it really well. You're looking at systemic change, and I think that for a systemic issue, it requires systemic action. And I think that the work that you're doing is well positioned to rethink the way that we're going to successfully address health inequities and the exacerbation that you saw after COVID-19. We have to make a fundamental shift in the way that we approach behavioral health. And if you think about it, what is the current system that's being used in the US in terms of a treatment approach? You have about 5% of the population that has a diagnosable severe mental illness, about 20% that just so severity 5%, 20% that have a diagnosable mental health disorder, and then 75% is everybody else. But 75% doesn't mean that you don't have anxiety, that you don't have trauma, that you're not experiencing. That 75% could very well move into the 20 or the 5%. They're just undetected. They go undetected, right? So one of the things that we've been working on at APA, and especially our CEO, Dr. Arthur Evans, is a fundamental believer in a population health approach. If you take the framework of population health, the goal around population health is to keep, healthy people healthy, mitigate the risks with early intervention in that middle at-risk category. And for the ones that are diagnosed, right, do effective and efficient clinical care. And so taking this approach now begins to imply and to advocate for a systems-wide approach that will start to cascade and trickle down into consolidating the disparate systems that are certainly not working together right now to approach this from a frame that allows for intervention at any one of those categorical positions. So I'm hoping that through this conversation, your work in Connecticut, your advocacy for change starts to really expand the way that we're thinking about this. Yes, we can have impact at the ground level. We can have impact at the institutional level. But wouldn't it be wonderful if we started to think about a frame like population health that would allow us to gut the current system and implement something that actually works to keep people healthy, right?
Something that's really a public health frame, right? That's really what you're talking about.
That's right.
In a holistic sense, and in a comprehensive sense that de-silos, because everything is so siloed. So, you know, the Department of Mental Health and Substance Use Services, the Department of Social Services, the Department of Children and Families, the Department of Education at the state level, they are all, and, you know, I'm not saying that there aren't collaborations, that there aren't efforts at being much more integrated, but we really do need to start over. We do need to start over, and that has to be a priority. Well, I would like to also, I mean, we are talking about it. What can the state do? What could our legislature do in Connecticut on this front? What's the role of the federal government? Because I'm known to say at the foundation that all roads lead to Washington. We can't do everything by ourselves. And there are a lot of resources. Pat and I had a conversation a couple of weeks ago where, you know, you said there is money. It's not like we don't have money. We claim, you know, we have this austerity mindset, but we do have money, and it's how we're spending the money, both at the state and federal level, that makes the difference. So let's talk a little bit of just a couple of minutes about the role of the federal government and the state government. Pat, you want to start there?
I mean, I think there is absolutely a role. You know, again, going back, I'm nearing retirement, so I'm thinking back on some of the things that used to happen. And there was a time when we would get a federal grant at DEMIS from SAMHSA to pilot something, let's say a mobile crisis team, which is turned out to be really effective. And we would go to the legislature and say, well, this is the money we need to spread it across the state. And at that moment in time, we would get it. That has stopped. And that was because we went through some fiscal difficulties in Connecticut. I think we're in a place again where we have got to look at what programs work and fund those. And it's very difficult, right? Because there's historical funding in this state. By the way, Misa, please say hello to Dr. Evans. He was the deputy who created the recovery model that I'm talking about. But, you know, there's historical funding. And I think that the fear is if you pull funding from providers, they're on such an edge that we'll lose providers. And yet, does that mean we should keep funding? I won't name anything that we know really isn't evidence-based and doesn't work. And, you know, we've got to really look at how we're spending the dollars and where we're putting the dollars so that we can move the system to a better place. And I think it is a complete overhaul that we need. And I do believe that there are people that actually know what works, what is evidence-based, trauma-informed care. We all talk about it, but how many of us are actually providing trauma-informed care? So I think that we've got to get to a point where we are brave enough and bold enough to say, doesn't mean as a small provider you have to go out of business, but you may need to do something different, and we'll help you get there. And I think that that is one of the major tasks that we have before us right now.
So I want to take that and pose a question to you, Misa, about the role of the profession, right? So there has to be a hue and cry for that kind of overhaul, because the political dimensions of all of that work, of all of that money moving around, always come into play and keep the right things from happening. We know that it happens every single day. And so there need to be champions, and the people in the community can be champions for themselves. They can, organize and advocate. They also need allies, and the profession can be allies. And so in your role at APA, what is the profession in a position to do differently, both on the direct service level, but also on the advocacy level?
Yeah, I mean, we have a very large advocacy infrastructure that really is pushing this type of cutting edge conversation. And in fact, we sat in front of the presidential COVID health equity task force, 3 times during its tenure, and talked about the importance of inclusion of behavioral health as a partner sitting around the table. Because I think, initial conceptualizations around how we were going to manage and treat COVID didn't include the thought that behavioral health and psychology was an important player. But then when we started to see vaccine hesitancy, right, and that we couldn't reach herd immunity because it's all about human behavior and the way that people react to things, mask wearing and resistance around mask wearing, all these are human elements and human behavior, right? And so I think it's important, if you're talking about, what can grassroots organizations do to really activate and call for systemic change? I want to kind of focus on 5 things that we've been focused on that can trickle down to the state level. We know that there is a symbiotic relationship, right? We have to have people at the community level, at the local, at the city, at the state level. And if we can come together and unify around some of these domains that are super important, imagine the impact. Then everybody's sort of asking for different things. We have to strengthen, like to Pat's point, we have to strengthen our mental health infrastructure. We can't think about how to address the mental health pandemic that's happening right now, the substance abuse and opiate crisis, the community violence issues that are happening right here in our own backyard, if we don't increase and strengthen our treatment and system infrastructure. Advocacy at the grassroots level, activism at the grassroots level, need to start focusing on that. How do we expand and increase that infrastructure? We need to use a whole government approach to address the impact of COVID-19, specifically for communities of color. What are the implications of long COVID, right? APA has been having a lot of conversations around the neurological impact that we still don't really understand what all of those neurological implications are going to mean for people's well-being and functioning, right? We need to enhance research and data collection, because without that, we don't understand where we are, and it's hard to predict where we need to go. We need to make sure that we're implementing early intervention strategies. We can't wait until, a child is 10, 15, 20 to start saying, oh my gosh, we have a problem. We've got to get them right after birth. We've got to get families we have to support and wrap around families and support them through the process really early on. And last, but certainly not least, we have to make an investment in building community resilience. We are a resilient people. People of color have gone through the most atrocious harms that you can ever imagine in our history, and we have overcome. Why not tap into an incredible resource that we have just internally and think about how community resilience can really support the birth of a new community that is attached to those that are elevating within that community, that can be leaders and role models in that community, and that can support resiliency at every level. So those are the 5 areas that we've been advocating really strongly for, and I hope that people here pick it up too and continue to champion for those.
I think that those are really on point. And there's a comment in the chat actually about neighborhoods needing to be a community again to watch out for each other. And it goes to your point about community resilience. And power concedes nothing without a demand. And that, isn't my quote, of course, that is Frederick Douglass. But the power of communities. And, when we talk about these issues, we have an opportunity also to be in very deep relationship across race, ethnicity, class, and economics, because these are issues. Yes, racism has skewed trauma against people of color. The effects of mental illness in families across the spectrum is real as well. It's real. And if there is any issue that could bring people together, I'd actually, maybe overly optimistic, but I actually think suburban white people, urban Black people, rural people, poor rural people should be able to come together around the need for these structural changes to support the development of their children and their families over time, to break that intergenerational pattern of inherited, Carl Jung called it inherited archetypes, right? I majored in psych as an undergrad. That's the extent of my psychological, my psychology background. But I will say that the families do inherit and pass on mental illness, and the impact of stress from the social determinants of health is really, really significant in families. So I want to ask you in the last few minutes for a call to action. What can organizations, this might be repeating my question in a way, but there's organizations with influence like ours, and then there are people affected by the problems in the system and their friends, their families, their neighbors. What can we all do to make sure that our policymakers understand that this is not just a crisis to call it a crisis, but that something real has to happen?
The one thing I can say, Frances, that has made me a little bit more hopeful about systemic change is that, as horrible as it is that we're in this pandemic with more people experiencing mental health issues, I do think it is helping to bring people together. And I also can tell you that, and I've been doing this a long time, and in the last 18 months, I've seen the most money donated to behavioral health than I've seen in my entire career. Mm-hmm. And I think that is a little bit of the breaking down of the discrimination and people understanding that, again, their child, their mother, their sister, anybody can experience this, any family, nobody is immune. And I think if we could take the energy from those families that have been impacted and get them together. And I think some of that actually is happening. And that's why we're seeing what we're seeing in the paper. And, there were 3 legislative bodies in the last 2 weeks that got together to discuss this. So people are noticing. And I think that is a positive development. It's still a big hill to climb, but I think getting people together and talking about the strains created by mental health issues or substance use disorder issues, it really does go across all the boundaries. And I think that's
someone wrote in the Q&A that there does need to be education, that people need to talk with one another and learn and understand the issues. And so that, that's at multiple levels, at policymaker levels, but also very much so at community level. Maisa, you've got the last word here.
If I had to today, right now, issue a call to action, I'm glad Pat is here because she is representing a large health system. It would be that we need to take a systemic approach to behavioral health, elevating families to be first, right? If we started to look at families first, as opposed to looking at the medical components, we would change our perspective and our view around that. We also need to have a great deal of education around racial trauma-informed mental health services, right? So not just trauma informed, but I would include that racial right before it, right? So that there's not just about cultural sensitivity, it's about understanding the implications of racism, the way that we've talked about it today, and the what are those impacts and effects to people's mental and behavioral health. And the last thing that I would say, and a call to action for our legislators, I know that some cities across the state have done this, but it should be declared all around, is that we need to declare that both racism and mental health are a public health crisis. Yeah. If we declare that, then we would start to be able to create that systemic change, Frances, that we've been talking about, because we need to then implement the funding and the infrastructure to create the kind of change that's necessary so that it can trickle down into communities.
Well, I'm like Pat, I'm hopeful too, because in fact, this year in the legislative session, a bill did pass as declaring racism a public health pandemic in Connecticut, and a commission was established that is charged with looking at how racism is embedded in all our various systems. So we're a journey of 1,000 miles starts with the first step, and I think we have to expedite that journey, because there is a sense of urgency. There really is. But I think if we can't do it in Connecticut, I can't imagine where it can be done, because we are a size that's very manageable. We have a rainy day fund. And as Sarah Egan said on an interview I heard her recently say, it's raining, folks. So we've got to act with urgency.
And with that declaration, it means that it is the civil right of every person of color to get treatment, related to the racism that they have been exposed to or endured, right? We're declaring it that it's a public health crisis. Now it is my civil right to get treatment for the racism that I've endured, right?
Absolutely, absolutely. Well, we're going to have to leave it there. We've run out of time. This has been a wonderful conversation. I really appreciate both of you, all the work that you're doing, that you've done all these years, and that I know you'll continue to do, and look forward to the continued partnership with us at Universal. So I'd like to thank all of the folks who've come today and participated through the Q&A and the chat. I've seen a lot of activity on the chat. I encourage you to look for the conversation on YouTube. We'll be posting it soon, along with the other conversations from the prior 3 events that we had. Follow us and share. And I wish everyone the best for the upcoming holiday season. Much gratitude, much health and happiness. Thank you all. Take care. Bye.